All right, so we're setting the stage today for two distinct conditions that often get confused in the clinic and, frankly, on exams like the MCCQE1, asthma and chronic obstructive pulmonary disease, or COPD.
Exactly. It's so crucial to nail down these differences. But to kick us off, here's the kicker. Did you know that the fundamental inflammation in asthma is driven by one type of immune cell, but in COPD it's a completely different set, even though both lead to breathing issues?
That's such a perfect hook because it really gets to the core of their pathophysiology. In asthma, we're primarily talking about chronic airway inflammation, often mediated by eosinophils, mast cells, and T helper type 2 lymphocytes.
So essentially, it's an eosinophilic Th2-driven inflammation, right? And that's what leads to the hyperresponsiveness and the reversible airflow obstruction that's so characteristic of asthma.
Exactly. That reversibility is key. Now, flip that over to COPD, and the picture shifts entirely. Here, the inflammation is chronic and primarily driven by neutrophils, macrophages, and cytotoxic T lymphocytes, those CD8 plus cells.
Wow, so it's a totally different cellular response. And with COPD, the airflow limitation is persistent and largely irreversible, which results from small airway disease and parenchymal destruction, like emphysema. That's a huge distinction.
Absolutely. And these fundamental differences in pathophysiology lead directly to very different risk factors. What's the biggest player for COPD that everyone probably thinks of?
Oh, the most important risk factor for COPD is unequivocally cigarette smoking, accounting for the vast majority of cases. But it's not the only one, right? There are others.
You're spot on. While smoking is dominant, we also see exposure to biomass fuels, occupational dusts, and a genetic predisposition, notably alpha-1 antitrypsin deficiency, playing significant roles in COPD etiology.
Okay, so that's COPD's lineup, but for asthma, it's a bit more multifactorial, isn't it? What are the key risk factors we should be thinking about there?
For asthma, we're looking at things like atopy, which is a genetic predisposition to allergic reactions, a family history of asthma, and exposure to common allergens like pollen or dust mites. Respiratory infections, especially in early life, and irritants such as tobacco smoke or air pollution are also significant.
So we have these two conditions with distinct underlying inflammatory mechanisms and very different primary drivers or risk factors. It's fascinating how different their origins are, even though they can present with similar symptoms initially.
It really highlights how crucial it is to understand these basic distinctions. And these differences extend beyond the cellular level and risk factors. They also manifest in how patients actually present clinically, teasing the diverse patient presentations we'll explore next. So picking up right from where we left off, these fundamental differences we've discussed really manifest themselves in the diverse ways patients present clinically, giving us our first clues.
Exactly. It's not just about what's happening inside, but how it looks and feels to the person experiencing it. For asthma, essentially, you're looking at symptoms that are pretty variable and episodic.
Right. They might be worse at night or in the early morning, triggered by things like allergens or even just exercise, and can sometimes even resolve spontaneously. It's that on-again, off-again pattern.
Totally. Compare that to COPD, where the presentation is typically quite different. We're usually talking about people over 40, and their symptoms are persistent and just progressively worsen over time.
Yeah, you often hear about chronic cough and sputum production being common early signs, along with dyspnea that gets worse with exertion. It's less about triggers and more about a constant worsening struggle.
And this brings up an interesting MCC question related to risk factors. Imagine a 35-year-old non-smoker who develops severe early-onset emphysema. What specific genetic predisposition is the most important risk factor to consider for their likely condition?
Ah, that's a classic MCC risk factors or etiology question. In that scenario, we'd be thinking about alpha-1 antitrypsin deficiency, which is crucial for early onset emphysema, especially in non-smokers.
Spot on. It really underscores how diverse the risk factors can be, even within conditions that share symptoms. But all right, moving from these clinical pictures, how do we confirm what's really going on inside the lungs?
That's where spirometry steps in as the cornerstone for diagnosis. It's how we get objective evidence of airflow limitation, right? Essentially, it measures how much air a person can exhale and how quickly.
Absolutely. Key parameters are the forced expiratory volume in 1 second, or FEV1, which is the amount of air exhaled in the first second, and the forced vital capacity, FVC, which is the total volume exhaled.
Then the ratio of FEV1 to FVC is super important. An obstructive pattern, which is characteristic of both asthma and COPD, is defined by a reduced FEV1 to FVC ratio, typically less than 0.70 or below the lower limit of normal.
Right. A low FEV1 to FVC indicates that air is getting trapped or having trouble getting out. It's the first big red flag for obstruction. And then the FEV1 itself helps us gauge the severity. And this obstructive pattern is where the diagnostic paths for asthma and COPD really begin to diverge, requiring further testing to differentiate which condition we're actually dealing with.
Diving deep into objective lung function tests, especially with spirometry, it's clear it's not just about seeing an obstructive pattern, it's about what happens after.
All right, so we've established spirometry shows an obstructive pattern. What's the critical next step in distinguishing between asthma and COPD?
The real game changer is reversibility testing. This is where we administer a short-acting bronchodilator and then repeat spirometry.
Okay, so what are we looking for? What kind of change indicates asthma?
For asthma, a significant reversibility is key. We're looking for an increase of at least 12% and 200 milliliters in FEV1 and/or FVC from baseline after that bronchodilator.
Wait, so to clarify, it needs to hit both those numbers, 12% and 200 milliliters, to really point towards asthma.
Exactly. That strong, clear improvement strongly supports an asthma diagnosis because its airflow limitation is variable and reversible.
This brings up a great MCC-style question then. A 35-year-old patient presents with episodic wheezing and dyspnea. Initial spirometry shows FEV1 over FVC ratio of 0.65 and FEV1 70% predicted. After bronchodilator administration, repeat spirometry shows FEV1 over FVC ratio of 0.78 and FEV1 92% predicted. What is the most likely diagnosis?
That's a classic setup. Given that significant reversibility, the most likely diagnosis is asthma.
And what about COPD? What does their reversibility testing typically show?
In COPD, the airflow limitation is largely irreversible. You might see a small degree of reversibility, but the FEV1-FVC ratio almost always remains below 0.70 or the lower limit of normal.
So it's the lack of that significant improvement that helps rule in COPD, even if there's a tiny bump.
Precisely. It really helps differentiate. Beyond spirometry, are there other investigations that prove useful?
Definitely. A chest x-ray, for example, is usually normal in asthma, but with COPD, you might see signs like hyperinflation, flattened diaphragms, or even bullae.
And for asthma, especially with an allergic component, allergy testing like skin prick tests or IgE levels can identify specific triggers.
That makes sense. What about when you suspect something a bit more specific, like a genetic link for COPD?
Then you absolutely need to consider alpha-1 antitrypsin levels. This is crucial for patients with early-onset COPD or basal predominant emphysema, especially if they're non-smokers or have a family history.
Right, because that deficiency is a significant risk factor we discussed earlier. Are there any other specific tests for asthma, particularly when baseline spirometry seems normal?
Yes, if asthma is suspected but baseline spirometry is normal, a bronchial challenge test, like with methacholine, comes into play. A positive test indicates airway hyperresponsiveness, which is a hallmark of asthma.
So it's almost like provoking the airways to reveal their hidden hyperreactivity. It sounds like these additional investigations, combined with spirometry and reversibility, really give us a complete picture.
They do. It's all about highlighting the most definitive diagnostic markers to make an accurate diagnosis. All right, so we've established the definitive diagnostic markers for telling asthma and COPD apart. Now let's shift our focus to effective asthma treatment. It's really all about mastering control, isn't it?
Exactly. And the management of stable asthma really follows a clear stepwise approach, with inhaled corticosteroids, or ICS, being the foundational therapy. These aren't just for emergencies, they're daily controllers.
That's a crucial distinction. So for immediate relief, we're still talking about as-needed, short-acting beta-2 agonists, or SABs, like salbutamol. But the source material explicitly states they're not recommended as monotherapy for persistent asthma, which is key.
Right. Using just a SABA for persistent asthma is like putting a Band-Aid on a gushing wound. The next step, step 2, is crucial. Low-dose ICS daily. Think fluticasone or budesonide. They reduce inflammation, which is the root of the problem.
And if symptoms aren't controlled with just ICS, we move to step 3 or 4, which introduces the low or medium dose ICS-LABA combinations, like fluticasone-salmeterol. The LABAs, or long-acting beta-2 agonists, help keep airways open longer, but remember, never use LABAs alone in asthma.
That's a huge point. For severe cases at step 5, we start looking at serious add-ons. We're talking long-acting muscarinic antagonists, or LAMAs, like tiotropium, or even oral corticosteroids, though those come with side effects. And then there are biologics for specific allergic or eosinophilic asthma.
Yeah, the biologics are truly game changers for those severe refractory cases. But it's not just about meds, is it? Non-pharmacological approaches are also vital. Allergen avoidance, smoking cessation, and patient education about inhaler technique and action plans.
Absolutely. Empowering patients with knowledge is half the battle. But speaking of severe, what about acute asthma exacerbations? These can be terrifying. The source poses an MCC question. A 28-year-old asthmatic patient presents to the emergency department with severe dyspnea, wheezing, and an SpO2 of 90% on room air. She is struggling to speak in full sentences. What is the most appropriate initial investigation and management step?
Wow, that's a high-stakes scenario. The initial management here focuses on oxygen therapy to get that SpO2 up to 92%, high-dose nebulized salbutamol, and systemic corticosteroids to knock down that inflammation quickly. That's the immediate triple threat.
Exactly, and if it's really severe, you might add ipratropium bromide to the SABA or even IV magnesium sulfate for those life-threatening refractory cases. It really underscores how dynamic and urgent these situations can be.
It really does. It's a rapid-fire sequence of interventions to stabilize the patient. So it seems we've covered the stable management with its stepwise approach and the critical steps for an acute exacerbation. That gives us a really solid foundation for understanding asthma control.
Definitely. It's about knowing when to escalate therapy and when to act fast in an emergency, which I suppose prepares us nicely for understanding urgent asthma situations or the next topic we are getting into.
All right, transitioning to strategies for managing COPD, the approach for long-term control is quite distinct from asthma.
Definitely. For stable COPD, the focus is squarely on bronchodilators, right?
Exactly. We're talking about LABAs and LAMAs as the preferred choices for long-term symptom control here.
So not like asthma where ICS are foundational. That's a key difference for the exam.
Huge distinction. ICS-LABA combinations aren't for every COPD patient. They're reserved for those with frequent exacerbations and elevated blood eosinophils.
Meaning ICS monotherapy in COPD is a big no-no. It doesn't help and carries risks.
Precisely. It's all about targeted therapy. Beyond medications, non-pharmacological interventions are absolutely critical.
Oh, for sure. Smoking cessation, hands down, is the most effective thing a patient can do to slow progression.
Absolutely. Pulmonary rehabilitation, annual influenza, and pneumococcal vaccines are vital too.
And oxygen therapy for chronic hypoxemia improves survival. But here's the kicker we talked about.
Ah, the section hook. For acute COPD exacerbations, the oxygen target is quite specific, SpO2 88 to 92%. So, to clarify, why is too much oxygen dangerous here?
Mind-blowing, right? Especially in chronic CO2 retainers, high oxygen can suppress their hypoxic drive, leading to worsening hypercapnia or CO2 narcosis.
Wow, that's a crucial management point for the MCCQE1.
Yeah, alongside controlled oxygen, we're using high-dose bronchodilators, systemic corticosteroids, and antibiotics if bacterial infection is suspected.
Like if there's purulent sputum, and for acute respiratory failure, non-invasive positive pressure ventilation, or NIPPV, can be a game changer, often preventing intubation.
It truly highlights those critical care nuances in exacerbations. What a topic to cover. Absolutely, it's definitely a peak energy topic for exam readiness. All right, so we've delved deep into asthma and COPD, and truly, it's a peak energy topic for exam readiness. To really bring it home for the MCCQE1, what are those absolute high-yield concepts we can't afford to miss?
Exactly. When it comes to diagnosis, the main takeaway is spirometry and, crucially, reversibility testing. Remember, for asthma, we're looking for that significant reversibility, an increase of at least 12% and 200 milliliters in FEV1 and/or FVC after a bronchodilator.
Ah, the numbers are key, right? And for COPD, that obstruction is largely irreversible. What about the core distinctions in risk factors and those pesky inflammatory cells we talked about?
Absolutely vital. Think smoking as the primary driver for COPD, and for asthma, it's often linked to atopy and allergens. Then, for the cellular level, eosinophils and Th2 lymphocytes are your asthma markers, while neutrophils and CD8+ cells point towards COPD.
Got it. So a key question for the exam might be, what is the most important risk factor for chronic obstructive pulmonary disease? And the answer, of course, is cigarette smoking.
Spot on. Now, shifting to management, what's the fundamental principle for asthma versus COPD, especially considering medications?
Essentially, for asthma, inhaled corticosteroids, or ICS, are the cornerstone, following that stepwise approach. But for COPD, we're heavily relying on bronchodilators, LABAs and LAMAs to manage symptoms. ICS monotherapy is a definite no-go for COPD, right?
Precisely. ICS for COPD only comes into play for specific patients with frequent exacerbations and elevated eosinophils, usually in combination with a LABA. And we can't forget the non-pharmacological heavy hitters for COPD, smoking cessation, which is absolutely the most effective intervention, and pulmonary rehabilitation.
Those are critical. Now, when a patient presents with an acute exacerbation, especially for COPD, we had specific oxygen targets. What is the most appropriate SpO2 target for a patient with an acute COPD exacerbation?
That's an excellent next best step in management question. For COPD, we're targeting an SpO2 of 88 to 92% to avoid worsening hypercapnia. And of course, systemic corticosteroids and bronchodilators are key for both, with antibiotics if a bacterial infection is suspected in COPD.
Excellent summary. But here's the kicker. Beyond just asthma and COPD, what other conditions might mimic these, especially on an exam?
Good point. So, what other conditions should be high on your differential diagnosis besides asthma if you have a non-smoker with chronic cough, recurrent infections, and partially reversible obstruction? Bronchiectases, heart failure, or even chronic rhinosinusitis are super important to keep in mind, depending on the full clinical picture. Don't let them trick you.
That's a fantastic final challenge. Really broadens the perspective beyond just the two main players. Thanks for guiding us through these high-yield concepts.
My pleasure. Hopefully this helps everyone feel more confident tackling those complex respiratory questions on exam day.
Absolutely. Remember these distinctions and you'll be well prepared to identify the most likely diagnosis or the next best step in management.